Welcome to our academic boardroom, and I hope that we enjoy this journey together. We are welcome to the academic boardroom, where we discuss drug, we discuss pharmacology. In today's lecture, we continue our lecture on antibiotic. In the previous lecture, we have discussed the mechanism of action of various antibiotics. We also discussed the resistant mechanisms of various antibiotics. Last lecture, we look at the sulfonamide, trimethoprim, and also their combination. And we look at their various mechanism of action. Sulfonamide actually inhibits the synthesis of folic acid by the bacteria through the inhibition of folic acid synthase, while the trimethoprim inhibits the same synthesis, but through the inhibition of dihydrofolate reductase. Their combination is known as cotrimoxazole, which is more effective. It has a bactericidal effect. But sulfonamide and trimethoprim exhibit bacteriostatic effect if used individually. Today we will proceed by looking at nucleic acid synthesis inhibitors. And then we'll be looking at quinolone and also fluoroquinolone. Let's begin with discussion on quinolone. The quinolone are actually synthetic antimicrobial agent having a quinolone structure. Nalidixic acid is the first member of this class of antibiotic. It was actually introduced in the mid-1960s, even though newer agent has also been discovered now. Let's look at the classification of quinolone. And the first generation of quinolones is nalidixic acid, epimedic acid. The first generation, but because of various limitations of nalidixic acid, which we will see later in the course of this lecture, is the fluoroquinolone, which the quinolone structure has been fluorinated, also with piperacin. And then we have the second generation quinolone, which is fluoroquinolone. A good example is ciprofloxacin, ofloxacin, norfloxacin, lomefloxacin, elosacin, and then fluoroxacin. This constitutes the second generation quinolone, known as fluoroquinolone. The third generation of fluoroquinolone or quinolone which is fluoroquinolone. They are levofloxacin, gatifloxacin, sparfloxacin. That constitutes the third generation. And then the fourth generation of quinolone is fluoroquinolones, trifluoxacin, mesifloxacin, and gamifloxacin. So these are the classification of the various quinolone that we have. We now discuss the nalidixic acid, look at the clinical uses, the mechanism of action, contraindication, and possible adverse effect. Nalidixic acid is a bactericidal against various gram-negative organisms. Gram-negative organisms like Escherichia coli, Shigella, Enterobacter, Proteus, especially Proteus mirabilis, and also Klebsiella, Klebsiella pneumoniae, and several of those species. But they are bactericidal against this organism. The mechanism of action of nalidixic acid is inhibition of DNA garage in the bacteria, which involve in the DNA replication. The organism inhibits, and once the organism is inhibited, the DNA replication actually produces a damaged DNA, because during the unwind of the supercoiled DNA strand, that to proceed to the development of daughter cells. This enzyme DNA garage is involved in this. And then once this enzyme is inhibited, the DNA will produce DNA fragmentation. And DNA fragmentation, we're actually going to produce a damaged DNA, and of course, and then the DNA will not be produced, and then oxygen, the DNA will not be replicated, and then multiplication will be arrested. And of course, the DNA, the bacteria or the organism will actually die. The pharmacokinetic, nalidixic acid is well absorbed when given orally. However, it's good for you to know that the plasma concentration of the free drug is highly inadequate to produce systemic effect, because this drug is rapidly excreted. However, that is to say, it attains a high concentration in the urine. The steady state concentration in the plasma is highly inadequate for a systemic effect. So, but on the urine, it's highly concentrated because it is excreted rapidly. What are the few adverse effects? For nalidixic acid, the adverse effect is limited or uncommon. But however, we have seen hemolytic anemia is highly associated with the use of nalidixic acid, particularly with people with G6PD, that is glucose 6 phosphodihydrogenase deficiency individual. It causes hemolytic anemia in people with the deficiency of this enzyme. And also allergic reaction has also been reported. Also, this in central nervous system, it has central nervous system effect. Effect like headache, effect like drowsiness, effect like visual disturbances, maybe encounter when used nalgesic acid. What are the clinical uses? Nalgesic acid is actually known as a urinary antiseptic, which is used in the uncomplicated UTI. That as a result of Escherichia coli, Shigella, and Brutus. So it is highly useful clinically in urinary tract infection. Of course, I've already told you that it concentrated more in the urine. It's also useful in diarrhea, in the treatment of diarrhea. Nalgesic acid is useful clinically in the treatment of diarrhea due to Brutus species or Brutus mirabilis, and also Escherichia coli and Shigella. It is useful in diarrhea. This drug has a serious limitation. The limitation is this drug is only useful, or its usefulness is limited to urinary tract infection and gastrointestinal tract infection. So it's highly limited. This is one of the limitations of nalgesic acid. It's limited to only urinary tract infection and gastrointestinal infection. And secondly, because of its low potency, that has also bring limitation. The potency is very low, and also its inability to have adequate blood concentration or plasma concentration. Also, it has a restricted spectrum of activity and high frequency of bacterial resistance, has limited the use of nalgesic acid. So for this reason, a better drug or better quinolone drug has actually been produced. Yeah, so let's look at quinolone as a synthetic drug, which is the quinolone was actually fluorinated with fluorine and to give fluoroquinolone. And this fluoroquinolone has many advantages over quinolone. And the first advantage it has over nalgesic acid is a wide spectrum of activity. In our previous discussion, the nalgesic acid has a narrow spectrum of activity, but fluoroquinolone, that is fluorinated quinolone, has a wider spectrum of activity. The side effect is fewer than nalgesic acid. Also, the chances of resistance is highly lesser in fluoroquinolone. It is also attained therapeutic blood level compared to nalgesic acid that have inadequate therapeutic blood level. And also it has a better tissue penetration. So these are the advantage of fluoroquinolone over quinolone, nalgesic acid. These are the structure that the student must get themselves familiar with the structure of fluoroquinolone. This is the fluorine, which is actually attached at um, 5 position. And then this is the pepiracine that is actually attached. So you have non-fluoxacin, ciprofloxacin, moxifloxacin, and then levofloxacin. So student is expected to get himself familiar with the structure of fluoroquinolone, at least to see the attachment of the fluorine, also the attachment of pepiracine that make it a better quinolone compared to nalgesic acid. Yes, just as we have said, that this is the structure. So these are a typical example of ciprofloxacin, especially the first generation of fluoroquinolone is ciprofloxacin. And this is the structure. This is the fluorine that is being attached at 6 carbon, and also the pepiracine that is being attached at 7 carbon position. As I've said, that because of this attachment, or because of this fluorinated of this quinolone, we have a better, it has a high potency, it has an expanded spectrum, and also the development of resistance is lower compared to nalgesic acid, and it has better tissue penetration and also good tolerability. Yes. So, of course, I've said we have shown you during the classification of this is considered to be the first generation of fluoroquinolone. And then the first generation involve are the non-fluoxacin, ciprofloxacin, perfluoxacin, or fluoxacin. And then the second generation, levofloxacin, lomefloxacin, perfluoxacin, gatifloxacin, moxifloxacin, and gamifloxacin. They are the second generation of fluoroquinolone. Yes, let's look at the mechanism of action. How does it act? Very similar to quinolone. Nalgesic acid, they actually inhibit bacterial enzyme, DNA garase, and topoisomerase 4, which are required for DNA replication and DNA transcription. So this enzyme inhibits DNA garase, and once the DNA garase is inhibited, DNA replication will be inhibited. Also, fluoroquinolone also inhibits the topoisomerase and block the separation of daughter cell. And then the bacteria will produce a damaged DNA, which is being degraded by nuclease enzymes. For this reason, the fluoroquinolone are bactericidal. They kill the organism outrightly. You can appreciate this very well. This is when this DNA garase is being inhibited, it interferes with positive supercoiling. During the replication, when the helicase at the replication fork, the organism tries to unwind or tries to separate, there is a formation of supercord, and this supercord has to be unwound. Otherwise, it will produce the DNA will be fragmented. And then, so once the DNA garase is inhibited, the damaged DNA will be produced, and that was likely going to be degraded, going to be removed by another enzyme, nuclease enzyme, and then the organism will die. That is bactericidal. And also the topoisomerase is involved in the separation of daughter cells. And when the DNA, when the topoisomerase is inhibited by fluoroquinolone, the separation of daughter cell will also going to be inhibited, and therefore multiplication will be arrested. So this is the beautiful mechanism of action by which fluoroquinolone kill or destroy bacteria. This is very interesting. I think it makes sense. Does this drug develop resistance? Yes. Resistance have been reported. So some microorganisms develop resistance against fluoroquinolone, and this can happen in 3 ways. Number one, it happens through mutation in the target enzyme. The bacteria, the antibiotic loses affinity for the enzymes. That is DNA garase, topoisomerase 4 enzyme. And when the antibiotic loses affinity for this enzyme, then the replication continues, and then the organism develop resistance. Number two, the organism changes its permeability of the drug to the organism. So there's a changes in the permeability of the organism to the drug. And the third mechanism by which it develops resistance against fluoroquinolone is the production of a DNA garage by some protein plasmid mediated gene or mediated reaction, so that more of this DNA garage is produced, then the replication will now continue. This is the various way by which resistance can occur in the use of fluoroquinolone. We look at the various clinical uses. Number one is highly useful in urinary tract infection, just as like nalidixic iron acid. It's very fluoroquinolone, whether ciprofloxacin, paclufloxacin, mesofloxacin, they are very effective in urinary tract infection, especially those that are caused by multi-drug resistant bacteria. The fluoroquinolone is very, very effective. Norfloxacin is generally used about 400 milligram BD, 5 to 10 days. The second clinical uses is in typhoid fever or enteric fever. Ciprofloxacin is the drug of choice in enteric fever, about 500 milligram BD, that is 2 times daily for 10 days, will be very, very effective. Even the carrier state is being eradicated at this use. This drug is also, fluoroquinolone is very useful in diarrhea, especially diarrhea due to Shigella, Salmonella, Escherichia coli, and Campylobacter. They respond very effectively to fluoroquinolone. It's also very useful in the treatment of gonorrhea as a result of Neisseria gonorrhea. A single dose of 250 milligrams of ciprofloxacin is highly curative. But in some few countries, resistance has been emerged or reported. So in those countries, ciprofloxacin is no longer the drug, the first line treatment for gonorrhea. Ciprofloxacin, especially ciprofloxacin, is useful in the treatment of chancro. It can be used as an alternative to otromozazone. Just in 3 days, you should be able to handle chancro. It's also very useful in respiratory tract infection. Respiratory tract infection due to Haemophilus influenza, Legionella, Mycoplasma can be treated with fluoroquinolone. Most fluoroquinolone are actually regarded and are very effective against most respiratory pathogens, including gram-positive bacteria, as well as the chlamydia mycoplasma. They are highly effective against this range of organisms. It's also very useful in bone, joint, and soft tissue and intra-abdominal infection. Highly useful osteomyelitis, joint infection, but they require a prolonged treatment. In tuberculosis, ciprofloxacin is one of the drugs in multi-drug regimen used for resistant tuberculosis. As a result of Mycobacterium tuberculosis, it's also very useful in atypical Mycobacterium infection. So it's a drug of choice in tuberculosis. It's also useful in bacterial proctitis, sapicitis, as a result of chlamydia. Ciprofloxacin respond very effectively. It has also found usefulness in ear infection. So ciprofloxacin or fluoxacin may be used as a topical application, topical treatment for the ear infection, and be used as a steer because most of the bacteria involved in ear infection responds to fluoroquinolone, especially ciprofloxacin or fluoxacin. They respond effectively. It's also very useful in anthrax. Of course, ciprofloxacin is a drug of choice for anthrax, and which have also been used in prophylaxis also. It is also very useful in gram-negative sepsemia. Gram-negative sepsemia is very, very useful, but however, it must be in combination with cephalosporin, aminoglycoside in the treatment of gram-negative sepsemia. Fluoroquinolone is also very useful in meningococcal infection or in a carrier state. That's find itself very useful there. Okay, I think it makes sense. So let's look at the contraindication where it should not be used. It is highly contraindicated in pregnancy. Fluoroquinolones will also be avoided among children below the age of 18. The reason is because fluoroquinolone damages growing cartilage and causes arthropathy. But this effect is highly reversible. Therefore, if the need be, it can still be used because the arthropathy or damaging to the cartilage can be a reversible clinical condition. Yes, it should be avoided avoided in patients with prolonged QTc interval. It should be avoided. That means we must be sure of the cardiovascular integrity of the patient before using fluoroquinolone. So, and also it should be avoided in those patients receiving drug that also causes prolonged QT, especially mefloquine. erythromycin, class 1 and class 2 antiarrhythmic drug. It also causes toxicity due to theophylline and other plutogenic drugs because they precipitate fluoroquinolone, because this drug, theophylline, most of the plutogenic drug, they are actually microsomal enzyme inhibitors, and then they're going to precipitate fluoroquinolone because the enzyme to metabolize the drug for excretion is being inhibited. So it must be avoided in combination with this set of drug. It also must be avoided, it must not be used concurrently with calcium, iron, and other preparation that contain theophylline cation must be avoided because it will reduce the absorption of fluoroquinolone, thereby reducing the bioavailability. So it must be avoided. Of course, in a renal failure, those adjustments should be done with people with a renal failure. Okay, so that's so let's look at the adverse effects. Even though the fluoroquinolone are well tolerated, but adverse effects like nausea, vomiting, abdominal discomfort, diarrhea, skin rashes has been seen when using fluoroquinolone. These are the few adverse effects you may encounter in the use of fluoroquinolone. Thank you very much for your time. This is the few things I think you need to know about fluoroquinolone. We will see you in our next lecture. It's interesting, so I hope this makes sense, and I hope you have gotten few information and for the use that can guide you in the use of quinolone and also fluoroquinolone. Thank you very much. We'll start.